And so I think we are going to have a very lively discussion during these days, because access and equal access is of a complexity that is completely intertwined with how we develop drugs and how we make our choices.
Two years ago, we organized the first meeting where we convened 100 invited people to answer the question, are we winning the war against cancer? And as a result of that, a declaration or an appeal of 10 points was put together, which was published very widely in the scientific and in the lay press. And we decided that some of these points should be discussed further. And so the European School of Oncology decided that the second WAF, this time, we should discuss the points of the declaration of the appeal related to treat the treatable, while next year we intend to have another meeting which will discuss the points prevent the preventable. So treat the treatable means for the developed world, what can we do to ensure that the currently available treatments and the treatments which are coming on the market can be used, and that they are sustainable for the health system, and what can be done to ensure that in the foreseeable future new treatments are developed which are financially affordable and more useful for the patient than some of the treatments that are available today. For the developing world, the situation is a bit different, because we are first to ensure that they all will provide a minimum package of treatment, including radiotherapy, since 30 or so countries do not have even one radiotherapy equipment, and at least the essential drugs which are necessary to complement the results achieved by surgery or by radiotherapy.
The message I brought to WAF really was that we have a problem in what I call the ecosystem. I think the ecosystem of drug development is broken, and I have a real concern that the whole community has become very risk averse, and I wanted to bring that message and discuss solutions with the group. I thought the discussions were excellent, because I certainly learned from the discussions, and I added to my mix of solutions to the risk aversion problem additional thoughts that came in from the other speakers and discussants, because it's quite clear that this is a problem that we can't just fix by any one solution. It's not just about tax incentives, for example. It's not just about adaptive licensing. It's not just about political will. It's about all of these things, and absolutely important is the need for public-private partnership. And one thing that impressed me, for example, was I heard a very similar message coming from Rich Shilsky from the US. He was really echoing the same sentiments and finding the same problems and suggesting similar solutions in the US, although he did comment that unlike in Europe, where my group and one or two other groups, Alex Matter's group in Singapore, public-private partnership, co-investment in not just the early stage research, discovering targets and understanding cancer, but also getting into the drug discovery, getting into the drug development, taking ideas further, in that way bridging the innovation gap. That's the problem that we've got. Huge amounts of knowledge about cancer pouring out of genome sequences. We know so much more about the biology of cancer, but the gap between exploiting that has become wider as, on the one hand, biological knowledge has grown, and on the other hand, industry has become very risk averse, all working on the same targets. And what's really important is that if we want to get to the solution to the problem that's become very clear recently of how to cure cancer, we have to overcome this problem of cancer evolution and the development of drug resistance, which is actually fueled by the drug treatment. You get selection against the activity of the drug. To overcome that, we need much more higher number of druggable targets to be drugged, and then we need industry to take those targets or early prototype drugs on. If we don't get these innovative drugs, innovation is key. If we don't get the innovative drugs approved, then we can't then move them into the early stage setting, adjuvant, and see more activity, and we won't have the opportunity to use them in drug combinations, which is what we ultimately need to cure the disease and to have long-term control.
Our urgent problem is to allow more access to the 90% of the world population that has no access even to the standard treatments.
The major inputs that is required to improve access to care are multifold. It is essentially a major policy initiative from the governments, from the national governments, to invest national resources within their own health services, improving the capacity of the health services in terms of the cancer healthcare infrastructure, trained human resources, national plans for improving, augmenting the oncology manpower, at the same time creating awareness among the general population on early signs and symptoms of cancer, where to seek services, and improving the capability of the primary care practitioners to recognize alarm symptoms and then promptly refer people to appropriate levels in health services. And then within the health services, the access is further improved by healthcare financing. You know, one of the major problems in cancer healthcare is the out-of-pocket payment at the moment in many patients in low-income countries are facing. So one needs a proper plan within the health services to have healthcare financing. And some of the important examples coming through the universal healthcare programs in countries like Thailand, some of the provinces in India, Brazil, and many of the Latin American countries is really an eye-opener.
Brazil is the biggest country in South America. We have 200 million inhabitants, and in the 5 different regions with different economic situation of the people. In the north and northeast, the people more poor than in the south and southeast, and this is makes a big difference related to access to information, to health services, to a different approach of the question of health for the people. Meanwhile, we have a national health system. It's a comprehensive, universal coverage, but we have many problems to guarantee access to people for all levels of the cancer control or health in general. We have a very structured program for cancer control involving activities from primary prevention until access to medicines and to palliative care. And we have a very good coverage for vaccines, for HPV vaccine. We started in 2013, and a good coverage for early detection for breast and cervical cancer. And we have 283 hospitals dedicated to treatment for cancer in the country.
it is important to reinforce the concept of cancer control. Early detection is important, proper treatment is important, but everything should be included in a common strategy from education, research, primary prevention, secondary prevention or early detection, proper diagnosis and treatment, palliative care, morphine access, end of life. Why? Because this is a continuum that should be coordinated at the country or at the health system level. But it is important in low and middle income settings to use the existing resources, to train primary care physicians, to train general doctors, because they are the force that are in contact with the patients. But a part of the patients, it is, I think, very important to create an idea that health means not only to treat the treatable or to cure the curable. Health means also to define a structure to maintain healthy populations. And primary prevention and environment and other issues are in this regard. Early diagnosis must be a strong tool if the primary care and general physicians are properly trained and educated. And the data today in low and middle income countries is that they have very, very fragmented information on cancer. And the point of treatment, there is, I think, a very widely considered idea that the best treatment, the newest treatment is the best. 80% of human cancers are amenable of cure or long survival with 17 or 18 drugs. All are generics, all are very cheap.
Well, we hope as a next step that we will be allowed to present this case at the next World Economic Forum, which should take place at the end of January of next year in Davos, since we were allowed already to present what we had generated with the first meeting of the World Oncology Forum 6 months ago in Tianjin in China at the so-called Summer Davos, and where new problems are exposed and where then a selection is made about the topics which have then the right to be presented at the big meeting in Davos. We do not have as yet the answer, but I think that if we will be allowed to present this, what we will ask for is, on the one side, a global action on cancer, and on the other side, that it is realized that the current methodology for developing new drugs and for evaluating new drugs is suboptimal, and that an international action on fixing new rules for the methodology for the evaluation of new drugs and for the pricing system for new drugs is absolutely necessary.